everybody. This is Paige Nuez. I'm with rettsyndrome.org, and on behalf of our board of directors and team, we're so pleased to bring you this week's series of free webinars to elevate your understanding and deepen your knowledge of Rett syndrome research and care practices. Your children are incredibly important to us, and having your attention and engagement today demonstrates your deep commitment as well. So we're very glad to have you with us today. For those of you who were with us yesterday, welcome back. We have a great lineup of speakers and topics today. For those who are joining us for the first time, I'd like to share some operational logistics of the GoToWebinar application, just briefly so that you'll know how it operates. The audio feed is open only for presenters, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you'll see a control panel window, and we invite you as an attendee to write in questions or comments at any point during Dr. Jones's presentation in the question box, and we'll answer them at the very end. If we don't get to your question during today's webinar, we'll work with our presenter to get all your questions answered through email. And if that control panel window is distracting for you, you can click on the small orange box with the white arrow to minimize the window, then click on that again to expand it if you wish to submit a question. The next thing I'd like to share is that this session is being recorded, and you will receive an email with a link to the recording shortly after our webinar week concludes. If you're having any trouble hearing, check the volume on your phone or device and turn it up, and we invite you to sit back, listen, and learn. Today we have Dr. Mary Jones, Medical Director for Katie's Clinic for Rett Syndrome at UCSF Benioff Children's Hospital, Oakland. Dr. Jones has been involved with Rett Syndrome for many, many years. She's one of those incredible physicians who not only spends her time in her clinic, but spends her time many hours outside of the clinic walls, traveling to IEPs with patients, traveling to therapist clinics, therapy clinics, whether it's therapeutic horseback riding out in the wide open or at children's services clinics. She also spends many times accompanying her patients to other doctor appointments. And during that time, she's observed a lot of communication opportunities to educate physicians about Rett syndrome and has observed just how difficult and complex that process can be, and has prepared a wonderful presentation for us today to help all of us as parents and caregivers prepare our correct records and know how to talk about our children in a way that will connect with whatever professional you happen to be working with, but specifically in a medical situation for an appointment, preparing for a procedure or surgery. So right now, I'd like to turn the presentation over to Dr. Mary Jones. We'll let her go through her slides. Again, go ahead and submit your questions to the question text field, and we'll answer them at the end of our time. Thank you.
Thank you very much, Paige and Megan, for the wonderful introduction. I'm Dr. Mary Jones, Medical Director for Katie's Clinic for Rett Syndrome at UCSF Benioff Children's Hospital, Oakland. Today's presentation is titled Dialogue with Your Doctors, Preparing for Appointments, Procedures, or Surgeries. And the purpose of this presentation is a look at the medical care experience from the perspective of the patient, the parent, and the doctor, to discuss the types of visits and to examine the format doctors commonly use for charting. Planning of a hospital procedure will follow, and will be handouts and a brief booklet will be available from Katie's Clinic or from the family section of the rettsyndrome.org website. I am, first of all, an RN, an MD. I got an MPH from Tulane in New Orleans, and worked as a public health nurse in New Orleans for a while before going back to medical school and becoming a pediatrician. One of the most amazing experiences after 32 years of pediatric practice was retiring this year to allow myself to teach residents at Oakland Children's Hospital, and to become the full-time director for the Katie's Clinic. The motivating experience behind all of this was a catch grant from the American Academy of Pediatrics that was granted to our clinic a few years ago. And during that, we learned about a medical home for Rett syndrome. It started us into schools and clinics and hospitals and visits with parents. We learned a lot from this. The sage advice for doctors caring for children with disabilities was given by a past president of the American Academy of Pediatrics. To our surprise, she said simple words: listen to the parent. The parent is the historian, the observer, the organizer, the reporter, the communicator, the educator, and the untiring advocate for her daughter. As you go through life with the medical profession, with the schools, you will feel the role of each one of these areas. Rett syndrome is a rare disorder, and it involves specialty care, ER visits, hospitalizations, therapists, and a primary care doctor. It's important that those who make decisions about her care have an up-to-date understanding of Rett syndrome, and that they communicate and that they plan together. Because Rett syndrome is not autism or cerebral palsy, therapy choices and surgical decisions may actually differ depending on the prognosis. Rapid advances in Rett syndrome research are happening, and you as a parent will likely be much more aware of them than the physician seeing your daughter. He needs your help. Most doctors wonder about these questions, but they find it a little difficult to ask. It's good to think about how to answer these questions before the visit. How much does she understand? How do you know she understands? Can she learn? What is her life expectancy? Will she continue to regress? What is augmentative and alternative communication, AAC? What is neurosensory regulation disorder? Practice a short version of Rett syndrome and let the doctor know that researchers are hopeful for better treatments and a cure. Individuals usually appear normal at birth, and then within the first year or two, experience a phase of regression. The regression comes to an end. That's important for them to know that. And the child experiences then the main symptoms of Rett syndrome, which are loss of purposeful hand use, replaced by stereotypies, loss of purposeful speech, difficulty with mobility. These are the characteristics of Rett syndrome. Cognition is not able to be accurately assessed with standards measures. Individuals communicate with eye gaze, facial expression movements, difficulty with neurosensory regulation, or the ability to filter input from the environment contributes to anxiety and the behaviors that she may exhibit. It's a new disorder. The gene was discovered in '99. It's not degenerative, proven in 2005. Symptoms were reversed in a mouse model, and drugs are in clinical trials. There's reason for optimism. Lifespan approaches that of a typical individual when given good care, and a natural history study of over 1,000 individuals found that individuals given therapies were benefiting from them. The progress may be slow, but continuous. Prepare a notebook. I have an asterisk here because one of my patients in my former pediatric practice always brought a steno notebook to each visit. She recorded her basic information, wrote her questions down, and then brought the information to every visit. And she always made notes after the visit, and she made us sign our signatures in her notebook after the visit, especially as new doctors in the private practice. We used to dread seeing her because her son had many problems. But as we got to know her better and as I practiced more, I realized the value of her efforts. Your efficiency in keeping a notebook may help the doctor spend less time writing in his electronic medical record and more time getting to know you. That is a pretty powerful sentence, because if you look at these doctors and the struggles that they have with changing medical records, especially the older ones of us, as we went from our paper records to the EMR. It's very, very, very helpful to provide him with, as efficiently as you can, with information that he needs. It also helps you to remember your questions and his answers. Keep your focus, even though you may need to care for your daughter during the visit. About your daughter, prepare your daughter for the doctor visit and discuss with her what will happen. Communicate with her at the visit so the doctor knows that you have expectations for communication. Recognize her presence. She understands more than she can really express. Your provider, before you come in, spends time reviewing your chart, spends time confirming and updating the medication list, the past medical history, the family history, the social history, importantly, the interim history, what's happened since you were last here, and the purpose of today's visit. In the EMR, a snapshot is presented. Your idea of a snapshot, in terms of your view, maybe an introduction to your doctor, or to your daughter, her best photo, a definition of Rett, as we've all been told to provide for give to our care providers. For your doctor, from his perspective, a snapshot of the provider's view looks a little different. This is what the doctor sees when you first enter the medical record. Rett syndrome can be daunting for him, especially in the emergency room or the ambulatory care center, where things go rather fast. Look at this problem list. Rett syndrome, seizure disorder, scoliosis, on and on and on. And then, if that isn't enough, the medication list. Notice here the doctor dutifully wrote down the same medication twice. Notice also that 3 of the medications on this list begin with the letter L. One is an anticonvulsant, another proton pump inhibitor for acid reflux, and another is just levocarnitine. It's really, really hard to remember all of these things and to spell them correctly. Again, another medication with 2 different doses written. When does she give these? Also important is your history. Many times as a hospital or your doctor have switched over to the EMR, your visits that you thought were embedded and readily available to the doctor are not quite so easy to get at. They become legacy visits. Sometimes these just show that you were there, and your real paper record is stored in the hospital. It's always there, but the ease of access is not quite as easy as we may have thought. The doctor hopes that you might have brought with you, hope against hope, a record of her weight and the dates they were taken, her current medication, the exact dose that you're giving her, not what was prescribed, but what you're really giving her, the time last given, the last anticonvulsant level if she's on a seizure med, and her weight and the dose that she was on when that level was drawn. List of other medications that have been tried, doses, and why they were discontinued is really a benefit and an added plus. A record of the test done, an EKG, the date performed, and not just that it was performed, but the result. The EEG, the date performed result, MRI, x-rays of hips and spine, old fractures, extremities, a hearing test. Was it ever done? A swallow study for her GI, a vision test, almost impossible to do in most school systems, and requires a referral to a good pediatric ophthalmologist. The tests that I mentioned above in your medical history are your power, and you have the ability to gather those, to record them, to keep them in a notebook, and to bring them. It's a lot of work. Doctors continue to use the same structured formats, and when the electronic medical record came in, these were placed in the medical record by physician advocates than physicians in a slightly different way, but they are asking for the same information. When the doctor sees the next step in your medical record, you recognize an HPI, a review of systems, history of present illness, a review of systems, a physical exam. The chief complaint is most important. It's important to be concise with this. Why are you really here? And what are the details of the chief complaint? The interval history is very, very important, as well as the history of the present illness, that review of systems. The past medical history, we must remember, never changes. So this can go in your book, and it can be recorded. This is a snapshot from another patient's history, and you'll see that the parent couldn't remember the date of the tonsillectomy, or was it done with an adenoidectomy and laryngotomy of tubes? Maybe it probably was. It's recorded here and in the medical record. When they say no family history on file, it means it's just not been taken and recorded. This is your power again to make sure the doctor has this on file, and it comes from your notebook. Again, the medications for this patient were quite complicated. The triage nurse for the physician has gone to great trouble to write down which ones were discontinued, which ones were ever used, and which ones are still being used. As you prepare your notebook, or this could be in your phone, but again, I recommend preparing a book of basic information. Write it down ahead of time so you don't have to think about it, and just carry the book to all your visits. Include a good photo of your girl that you could flash in front of the pediatrician or the ER doctor, because she may not look that way at this visit if she's ill or in distress. Her allergies, medications, problem list, birth history, development, hospitalizations, surgeries, and what was done, the dates of these things, the family history. These don't change as much. They may need to be updated, but they don't change. The social history does change. A marriage, a remarriage, a divorce, the death of a family member, the departure of a loving caregiver. Previous tests that were done should be recorded, but you may want to update her current labs. Ask for a paper when these labs are been printed out and put it in your notebook. A growth chart. One time, you don't have to put the plots in, but if you have the dates, weights, and head circumferences, it is a great help. All of these things roll over into the doctor's medical records. So this is your format for constructing your own book. He wants to know these things, chief complaint, review of systems. And the review of systems actually, as we go on, reflects the specialists involved in your daughter's care. They should include her general mood, her skin condition, her dental care, GI, chewing, swallowing, reflux, constipation. Breathing is her pulmonologist. Sleep, pain control, is she in pain? Her mobility, did she quit walking on one leg? And does she have periods? Questions doctors many times really like to skip over and don't ask because it's hard. The frequency, the length of the episode, and what relieves an episode that brought you to the doctor in the first place. The physical exam should include your own observations. Check every body part every day so you can describe the differences and then ask questions about them at the exam. Assessment, at the end of the exam, what did the doctor think? Make sure you understand what he's thinking. And the plan, this is where HIPAA or privacy comes in. You need the doctor's names and emails, but you also need a secure way to send him information, for your doctor to send him information. And that right now is a fax. Sometimes opening secured emails from medical centers is really hard for a busy physician to do. Sometimes taking photos of business cards in your own phone are helpful when you meet someone new and need to have the doctor, your own doctor from the visit, send on information to him. And in a little more detail in some of the problems in the medical record, the chief complaint, the doctor really wants to know, why are you here today and what do you hope to gain from this visit? Not what he wants to tell you, but what do you hope to gain? The history of the present illness and how long it's gone on. Is there pain, fever? Has she done it before? Is this a usual thing that happens? The past medical history, again, this doesn't change, and you can write it in your book. Your baby book and your pediatrician's visit records may be worth obtaining and writing down. Spend a little time to construct this. A baseline description of the child's mobility and communication before regression is many times helpful. Diagnosis and mutation. The allergies, sensitivities to medications or anesthesia, which is maybe different than allergies. Surgeries. Again, what was done? A G-tube, was there a fundoplication with the G-tube? What year was it done? Hospitalizations, reasons and dates. The review of systems, which rolls over into specialty care, as you can see. In general, the level of function of the child and her ability to communicate could be brought in here. Her head, dental care, problem, you could segue into problems with sedation in the past, for dental care, cavities, pulmonary, hyperventilation, breath holding, pneumonias, cardiovascular, cool hands and feet, a chance to mention prolonged QT interval if she had it. Was she ever assessed for it? GI, chewing, reflux, constipation, all of these are part of the GI system. Urinary tract infections, toilet training, kidney stones, possibly from medications used. Mobility, her current level of function, or sit to stand, or sit alone, walks, crawls, what does she do? Neurology, seizures and dystonia. Neurology, movement disorder crosses into your orthopedic care as well. Endocrine, again, periods, regularity. They could indicate another difficulty with an endocrine function. When you make your observations, remember that they're really important, and do check her over completely before the visit. No big surprises. Skin breakdown especially, mobility, painful crying, her appetite or weight loss, her mood or sleep, her energy level. These are important for you to think about. They don't necessarily need to be discussed with the doctor. They just need to be thought about by you. Her physical exam at the visit, weight is a must. Take her out of her chair or her walker if she's in one. Take off her equipment and her clothes for the exam, but do keep her warm in a blanket and stabilize her. Sit with her or balance her or hold her on the table, and remember to preserve her modesty. This is what the doctor is confronted with as he's recording your physical exam. And as you can see, it's not necessarily a template geared to a patient with special needs. The doctor has the option of checking these things to make it easier for him, but many times with a special needs patient, he's going to have to write it in or type it in himself. For the assessment, make sure that that you agree with the doctor's assessment. If you still have questions, go back to your list and check. Plan needs to include when to return and the purpose of the visit. You may be driving 200 miles and he asks you to come back in a couple of weeks. What will the purpose be? Who are you to see? And will a phone call with reporting suffice? What data do you need to collect that will be of benefit to him? When referrals are made, when should you go? To whom? Is an authorization needed? A letter sent by the doctor? Make questions for the next visit. And leave him the detailed updated information sheet on Rett syndrome that you've hopefully brought with you. Information about Rett syndrome for the physician can be given to him. I won't go over this now, but it's very valuable to carry or to leave for him. Functionally speaking, what does this really mean? It means a loss of purposeful speech, response time is slow, loss of purposeful hand use, difficulty with motor planning, neurosensory dysregulation. Doctors aren't taught this in medical school. It just simply means difficulty filtering out input from the environment, like noise, bustling, lights, too many people. Proprioception or balance is affected, and that translates into a fear of being moved. Anxiety is enhanced by all of the above. It's good for him to have this sheet, to know that, to at least go over it one time. You will see that there are different types of visits, and these visits vary by detail-oriented in the time spent. The general office visit and the follow-up are different. They're really different. The hospital follow-up, the ER, the planned surgery, the anesthesia pre-op, they use the same format, that same format we discussed, but with a different emphasis. Your organization is very valuable. Your specialist interests focus on the system involved, but that doesn't let them out of knowing what medications are used for different problems, because they may have side effects that affect other specialties. So each doctor needs to be aware of the other doctor's treatments. And referrals in the electronic medical record are many times briefer than we would like them to be, especially referral from one specialist to another. The parent's information is, again, very, very valuable. For the emergency room, the basic information is needed, and that chief complaint really comes in here. Medical information is very important. You'll be asked by the triage nurse and the doctor, and probably by the discharge nurse. A baseline photo, again, helpful to have here. Seizures, abdominal pain, loss of mobility, breathing problems, and pain of unexplained etiology are the most common reasons that you visit the emergency room. By definition, these things bring stress, and they come on in an acute manner. And there are things that can cause you to be discombobulated. So again, bring your book. For the ER, one of my favorite doctors in the whole world, and who's very, very wonderful, when asked, would you like to know more about Rett syndrome? After I carefully explained abdominal pain, gallbladder, constipation, renal stones with an anticonvulsant, typical causes of abdominal pain, he replied, thanks, Dr. Mary, I'm good. So it's on the need-to-know basis. This doesn't mean he's not a good doctor. It means that he doesn't need to go into the details of the genetics of Rett syndrome. If he had more time, perhaps he could do this. New doctors need to allow more time in their schedule when they're seeing you. Tell the receptionist ahead of time. Bring a summary or a problem list. Dr. Skinner and the little one, Brianna, are reviewing all of her records, but the new records many times print out way, way, way more information than you need to know. And this is daunting to a doctor. So your summary, again, is very valuable. Your primary doctor is your medical home. Make him a Rett expert. He may not have seen a patient with Rett syndrome before, but he can learn. And Rett syndrome is not CP or autism, and help him to understand the differences. He will need to help you with choices to be made in your plan. He'll need to make referrals and help him to do more than just sign prescriptions for equipment recommended by your therapist. Show him the choices. Show him the advantages to each one, goals for treatment, and how you plan to get there. Share her improvements and give feedback on her therapies. Offer to help him write a letter to send to the insurance or to the school. Help him get to know her or her to get to know him. This is a statement by Dr. Andreas Rett, and it really says it all, and we must remember that as we encounter the medical system. He said, I tell all the parents to look at their eyes. Their eyes are talking to them. The eyes are talking to them. I'm sure that the girls understand everything. This is by the person who described Rett syndrome. And one of our specialists really came around after 10 days of working with our patient in the hospital. He told a joke, and she laughed and made a raspberry. He said, she really does understand what I said. Specialists may have seen others with Rett syndrome, but the course of one child may differ greatly from another. The mutation type, the axon activation, the genetics of the family, and in the last few years, the therapeutic environment really has made a difference in the girls. To plan a procedure, this is a whole other ballgame, and this needs to begin early. It's not something we like to talk about, but it's something that needs to be thought of. I always think of the worst case scenario and hope for the best. Choose a center that has a PICU, a pediatric intensive care unit. You may not need it, but if it's there, it can provide resources for your physician. Choose a doctor or dentist who has knowledge and is willing to learn about Rett syndrome. That willing to learn is big. Prepare for the unexpected, hope for the best. Note the location of the ER in your hospital and where you would park if you had to go there on short notice. Office sedation may not be appropriate for many procedures due to sensitivity to anesthesia and prolonged wake-up time. You may end up in that hospital transported by an ambulance if you're not aware of this, just to have the child wake up because it's awkward in a provider's office to stay all night when you hadn't planned to. For a major procedure, consider contacting a Rett clinic beforehand to discuss it. Scoliosis and GI guidelines are available in booklet form for your physician. Have available the past medical history, latest test results, the current EKG, medication list, drug levels, last weight, recent labs, and x-ray results. Even when you're contacting the Rett clinic, make sure that they have this information available if they are doing a quick consult on your child. Try not to discuss your child as though she is not in the room when you're seeing a provider. Preparing for the procedure, you want to discuss probably the post-op home care from the start. Even if it's a simple procedure, will she need pain medication? Is feeding affected by her dental work? How will I hydrate her? Will she be constipated by the pain meds? How to watch for complications? What do they expect? Include a safe lifting plan because many of the children have osteopenia. If you need to get a new wheelchair or hospital bed at home, think about the transportation home. If they cast her legs or her ankles, will she fit in her car seat? Lifting to the middle seat in a van can be very rough if you're not very tall. Be aware that the previous car seat may not fit anymore. And to restore safe mobility and balance, you may need new equipment at home. Reducing your child's anxiety and your own anxiety. Parental anxiety, when you have it, makes the anxious, sensitive child more anxious. Prepare yourself as well as your child, and that's the best you can do. Increase your understanding of what's to be done. Explain the procedure to her. Careful explanations and planning ahead of time really make this process easier. Ask about a pre-op child life visit if you're going for a major procedure. Meet the nurses. Take a small tour of the hospital. Take a photo for her with the doctor or nurse. Personalize yourself. Reassure the siblings because they'll be worried maybe if she goes to hospital. Look at photos at home of the doctor and nurse and talk about it. Talk about what will happen and that you'll be there with her. Prepare for permission and check for permission to use electronic devices. Bring batteries or chargers if necessary. Organize a team, and this team looks very much like your review of systems plus a few. In addition to your orthopedist, GI person, neuro, pulmonary, and it'll include an anesthesiologist, palliative care, or child life person. Palliative care, by the way, does not necessarily mean end-of-life care. It means comfort care in the hospital. Your PT, your OT, inform them if you're having surgery. Your case manager, equipment, transport, home care. You discuss all of the issues with her in advance, the respite that you may need as she recovers at home. We won't go through all of the details, but just know that the GI specialist has certain issues that are unique to Rett syndrome. Cholestasis and pancreatitis can be a little bit unusual, and again, the crossing of specialties. You may need to bring this up. Pulmonary, I feel the most sorry for this doctor who hasn't seen many patients with Rett syndrome because of the breathing dysregulation and what it means. Scoliosis and kyphosis may make the airway a challenge, and this also crosses over into anesthesia. And anxiety by the equipment that we prescribe for someone on a routine basis on a post-operative care. Orthopedic, this is where you really come in. We need to look at the girl. We need to see things. We don't want pressure sores occurring under and around edges of casts and braces when they're on for a long time. When can she resume her therapies? And be specific about this. Ask your doctor for this information. Write it down. Osteopenia puts a girl at risk for increased risks of fractures, for awkward lifting that may occur when devices are needed post-op. Rett syndrome patients are very sensitive to anesthesia, and this is worth a meeting with the anesthesiologist ahead of time, at least to make sure that they have this information. And it's very important for your doctor to have this and to share it with the anesthesiologist and to confirm that it was done. One of our biggest risks is the transition of care from one department to another post-anesthesia recovery. And the sign out from the operating room, because it's really different when you're operating on someone or putting them to sleep. It's different than waking them up. This is the nursing care that needs to be happening. They need to understand about Rett syndrome. They need to understand about proprioception. They need to understand that her response time is slow. They need to understand how she communicates. They need to understand what her baseline is and when she can actually leave the recovery room to go back to the unit or the floor. Girls may have tremors that look like seizures, and shaking could mean pain, anxiety, or just deregulation of her neurosensory system. And if you're not expecting this as an RN in the recovery room, it's a little daunting. So second opinions from other doctors or other nurses may be required. And don't forget that parents may be just the person to give the opinion on when she can return to it, when she's at her usual state. The pain care team in the hospital, that's part of your team, needs to know about what worked in the past, and they would prefer to have a standardized pain scale for use throughout the hospital. Some use FACES, some use the FLAC scale. We'll show you an example of this later, and you can practice with it at home. To rate your daughter, you need to have this interface, talking in terms of the medical profession, talking with them on their way of charting and recording items about your daughter. Discuss ways to reduce anxiety. This is big. This is a picture of our FLAC pain scale that I'd recommend practicing with home just on a routine basis, so you kind of know what the child is how she'll be assessed when she comes to the doctor. Other people that I didn't mention earlier that could really be helpful on this team are the chief resident if you're in a major hospital, and the nursing supervisor. Ask your doctor about contacting them and providing them information on Rett syndrome. The hospital environment provides lots of neurosensory challenges, and again, physicians and many nurses are not familiar with neurosensory regulation disorder, but all of these can really disrupt your hospital stay and need to be planned for in advance. Nurses are a big resource, and they make a nursing care plan. Help them to construct it by providing them information in advance. I can't tell you how important it is not to hurry, to be careful with lifting, and to filter this information from the environment, the environmental stimuli like bright lights, noise, and new people, and to check every body part, every shift. Check under her clothing, turn her over if the orders permit, and look at her. This will prevent very unpleasant circumstances that might occur from just looking at the patient in her bed and being afraid to touch her because she has a rare disorder and is nonverbal. Nursing and doctor care, that care plan needs to be carried out We need to be aware of the need for one-to-one from the parent or the staff or the nurse. Unfortunately, the shifts change. Doctors change staff on weekends, and MDs cross-cover at night. It's important to remind each new face that you see who's taking care of her that she has a care plan. And it should include, again, you may have to go over it all again, remembering the IV team, if an IV came out, the IV starts are difficult, remembering to lift her very carefully because of osteopenia. For mobility, discuss what she's allowed to do and make sure your doctor has written that in your care plan. Prevent contractures from just lying there doing nothing. When can she start moving again in therapies? For the discharge from the hospital, again, plan early. Maybe from the minute you come in, once procedure's over. Ask for a copy of her latest lab and put it in your notebook again. Know what surgical procedure was done. Know if any anesthesia problems existed. Know about her discharge medications and plan on how you're going to get them and pay for them. Where are you going to buy them? Have on hand a working thermometer just in case. Tylenol suppositories. Get the right dose from your doctor. A constipation plan, unfortunately. Include glycerin suppositories that are over the counter. Future appointments, the purpose for them, the transport, the car seat, the lifting, the home equipment ready, and when can PT be started? For parents and caregivers, your parents as partners in the medical team, really valuable partners. But you need to be educated and responsible for the information that you bring to your medical team. Your partners that play the most valuable role in your daughter's care. And thank you very much for listening to our presentation. We value your input, and I'm happy to answer any questions.
Great. Thank you, Dr. Jones. That was an amazing presentation. I hope our attendees are not sitting there feeling very overwhelmed. Many of us came to Rett syndrome without a medical background, and I know it's a daunting task to suddenly feel like you need to be the expert in all areas. The goal of this presentation was to relieve some of that pressure and anxiety, not add to it. I know many of us feel that it's a challenge to repeatedly be the expert on Rett syndrome, but I hope Dr. Jones helped you understand why it's important. With over 7,000 rare diseases that the average specialist could encounter in their waiting room or in their exam room, you know, we kind of need to give people a break and let them be the expert at what they're the expert at. But you've given us some really practical advice of ways that we can prepare ahead of time to document these things. So a lot of people are asking if your slides can be available after the presentation. I just wanted to remind you that we are recording this presentation and we'll send a link out. And Dr. Jones is going to prepare a short handout that will have the forms that you can fill out for your child and keep them. On our website, rettsyndrome.org, we have great examples of what we call an All About Me book, which I would really recommend every attendee, every parent, every caregiver prepare one, whether it's for the classroom or for a physician, that has all the information about your child. It shows, you know, like Dr. Jones said, her wonderful, happy baseline self, and then documents all of the information. So with that, I just kind of wanted to lower everyone's anxiety a little bit and let you know the reason we're doing this talk is so that you can prepare now. Summertime is a great time. Things slow down a little bit. Organize your records, put the binder together, and then you'll be prepared to focus on whatever situation comes up. So just wanted to make that reassuring comment because I know that I feel overwhelmed at times about keeping my own daughter's records straight and updated. So Dr. Jones, if you have time, we have about 15 minutes left. We have a number of questions that have come in from the audience. So if you can, I'm going to read them off in the order that they came in, And if we don't get to all of them today, then we will we'll definitely answer them afterwards and email the questions and answers out to everybody. Okay, so we have a question from a parent of an adult with Rett syndrome, and she said that her daughter has had to have an appetite stimulant for several years. I'm going to probably not get this medication name correct, but dronabinol. And she's wondering if you know if this is common for girls with Rett syndrome, and it causes her a lot of drowsiness and is disruptive of her sleep schedule. So I know that's a very specific question.
It's a pretty specific question, Paige, and I think you have to look at whether the medication is helpful for stimulating her appetite, and if it is worth it to for the disruptions in her sleep schedule and for drowsiness. If it's working to help with her appetite, it may very well be worth it. I would almost question whether it is if there is this much drowsiness and disruption of sleep. That being said, there are many ways that sleep can be disrupted, and describing those with the doctor is very important as well. This may be a question for the Rett clinic, and I'd be happy to discuss this in more detail as well. I can be contacted through Katie's clinic, and I'm happy to respond in more detail. Thank you.
Sure. Is this a case where you might want to ask your two specialists, say your GI doctor who is helping you with her appetite, and say the neurologist who might be working on sleep, to talk to each other?
It could be, but this I see this as a question, or as a very, very critical point for the parent to share her observations. Again, keeping the weight records. Has her weight steadily gone up? Is she able to maintain her weight? If the specialist agreed to take off the medication and look at it for a while, does her weight drop? But this is how the parent can keep her records and can keep can very much supply into the medical team. So the parent's observations in this case would be a very, very big help to both specialists.
Great.
I would probably begin with a primary care doctor. Yeah.
Okay. Thank you. That's great advice. We have another question from a parent of a younger, fairly newly diagnosed child who is curious about what specialists they really should be seeing. They're seeing a neurologist, a physical therapist, occupational therapist, and a speech pathologist. What recommendations would you have for going ahead and getting baselines and building a medical team for this family?
I think that looking at the definition and the complications that could occur in different systems in Rett syndrome, I think that we want to know that many times osteopenia or weak bones are part of Rett syndrome, but that doesn't mean that we necessarily need to see an orthopedist. It means that your therapist need to know that these are possibilities with Rett syndrome. So looking at the complications that the systems involved in Rett syndrome is important. I would look at the enriched environment, which from Katie's clinic is probably our mantra, and that is looking at mobility. What helps with her mobility? What helps with her communication? A speech therapist may transition into augmentative communication, and knowing the basis of Rett syndrome, that movements are slow, response time is slow, and loss of purposeful speech. In other words, producing speech may not be our goal, but communication is our goal. Looking at the socialization, finding groups for her to be involved with and motivating her, motivating yourself for fun and providing entertainment in her life, and looking at then her medical health. I think you've probably, with a young child, you've accomplished very good specialists right now. We don't need to go looking for more, but to make sure everybody on the team that you have so far understands what Rett syndrome is and what systems are affected.
Thank you very much. We've had quite a few questions come in about dental exams and anesthesia. Can I'm gonna, we can, in the interest of time, kind of give you the list of issues that are concerns, and if you could talk about this for a minute. One of the questions is anesthesia needed at every visit for our kids with Rett syndrome for routine procedures, like if a filling or a cavity is needed, is anesthesia needed for that, or could a local anesthetic be used? And another parent's child is getting ready to have her wisdom teeth removed, and is there any particular advice if they absolutely are going to receive anesthesia, and it may be in an outpatient clinic, or should it be in an inpatient basis for something that's a little bit more involved? I know there's a lot of discussion in the field of our families about the use of anesthesia, especially for dental care and recovering with aspiration concerns. Hopefully I got all those rolled into one.
It's a lot of questions. I think that the dental care is one of the hardest issues in Rett syndrome. Many times, if a dentist is really patient, it's possible to get in someone's mouth and get a good look. X-rays are taking it to the next level, and that's harder because it's really hard for the girls to hold still. So an anesthetic many times is needed. I feel that because of prolonged wake-up time, because of issues in Rett syndrome involving anesthesia, that the kids are very sensitive to anesthesia. Because I've had patients who have had to be transported from offices to hospitals, that the place where they do the anesthesia needs to have an option for resuscitation of children or of people with airway difficulties, and it needs to have the ability to allow a prolonged wake-up time. In other words, the office can't close at 7 o'clock in the evening. It needs to commit to a longer wake-up time to make sure the child is safe to go home for hydration and care. So that being said, in general, probably a hospital setting is preferred. If a dentist could do a local anesthetic and soothing music and calmness could be achieved in the office, I think that's fine. I think that's an unusual case. So that would, but again, this is my personal opinion. Thank you.
Thank you, Dr. Jones. And I know a lot of parents have asked in the past, how do they find a dentist who is skilled in this area? And I just like to offer from our experience, we found that it's if you contact most medical dental schools in your area, they are typically a great resource because they have all of those facilities on hand. And it's not that a student will be doing a dental exam on your child, but they usually have the most senior experienced dentists in the area who are teaching new dentists. So if you've had trouble finding a dentist, I'd recommend reaching out for any of the dental schools in your area. Is it okay that I offered that advice, Dr. Jones?
Paige, I think that's the perfect advice. And it also, even though these schools have a long waiting period, it's a good idea to sign up, and they're worth the wait.
Yeah, and they usually always accept Medicare as well, in addition to your primary insurance, and that's for families in the U.S., of course. Okay, so we have another question, and this is a very good question. An unfortunate situation happened recently where a family, the father took their child for an unexpected x-ray appointment. He didn't have the stroller with him, and she got very, very upset when walking out of the clinic, kind of went into a rage, and some nurses at the hospital called security out of concern that the husband was hurting her child. And of course, the dad was mortified. So the parents are asking if there's some ways, some specific holds or procedures or ways to communicate in that kind of very misunderstood situation, how to handle that in a public place so that everybody understands what's really going on.
I think that carrying a card describing Rett syndrome and also describing neurosensory regulation and anxiety, and handing that to someone who may be not understanding about their child, and to the security personnel, appreciating their help, and sometimes it's even good to show the people who are caring for her before something happens, like in X-ray, in the lab, the nursing care team, when you check in, letting them know that you have information about Rett syndrome and about anxiety that may happen during these procedures. So to go up front about it is not a bad idea. And again, that I feel very, very badly for this father, and then this does happen. But the carrying a card or information is probably wise at all times about anxiety, because people, even at Disneyland or Costco, look askance when your daughter unexpectedly is frightened or screams or does a behavior as a result of being frightened or anxious, and it's hard to know how to manage it exactly.
Thank you. That's a good recommendation, and I agree with you. I think advising the department staff ahead of time that such a thing might happen and ask for their assistance is never something that you'll probably be turned down for, and they would appreciate and are usually happy to provide. Okay, so we're getting very close to the top of the hour. We have two more questions if we can fit them in. If not, as I said, we'll work with Dr. Jones to do a question and answer document and distribute it to all of our attendees. We have a parent who has a question for you: how to diplomatically request that the physician do an undressed and out of wheelchair physical. You mentioned that that's important, but this family has a doctor who doesn't ever do that for their child. How do you recommend?
I think that you can safely say that it is recommended by a Rett specialist. The reasoning being behind this are that when an AFO comes off, when an orthotic comes off, if it leaves a red mark for more than 20 minutes, it may not be fitting, even though it's new and fine. The chances of missing something by not seeing everything in the girl, as a pediatrician, I can regrettably say that the times when I wish I had looked closer will always come back to haunt you. It's worth the insisting. Many times, if he's worried about slowing down in the office or maybe offending the child, and so that these are things that need to be taken care of ahead of time. I think informing the nurse that you're going to undress the child because every body part needs to be looked at. You have a question. This is and keeping her warm and respected and modest. Informing the nurse that it's going to take extra time because you're going to do this. Showing him that you're willing to do this is really important. And this doesn't have to be done for every single follow-up exam, but it does need to be done if you're concerned about something at home, or if the patient needs to be done at the patient's regular visit every year or every 6 months, because things can sneak in, and it's very, very, and it's a very, very, unfortunately, a very important thing that needs to happen. It's especially important even in hospitals when the child is covered and when people are scared to touch somebody with osteopenia or possibly a scoliosis surgery or possibly a sleeping child that when she wakes up may become more disruptive. So his concerns are justified. It is going to take longer, but it's still very, very important.
Okay, great, thank you. So again, to enable time for this and take the pressure off when you make the appointment, make sure to talk to the scheduler to ask if they can plan some extra time, right? And that will ease some of the rushing that is happening. And allow
and at least a room page where she could be undressed, right, without disrupting the flow of patient care. And then it really shouldn't take any longer for him to see her after if she's undressed when he sees her, and he doesn't have to be a part of redressing the child.
Okay, wonderful. Well, we're at the top of the hour, and we do have some additional questions, so I'll get those over to you. We'll prepare a QA document. But I also wanted to remind everybody to look at the schedule for the rest of the week. If you had questions about GI, DEXA scans, osteopenia, those will be addressed in the GI talk tomorrow, and we have a presentation from Dr. Percy that goes over a lot of the common system issues that Dr. Jones talked about in the specialists. So please take a look at the future schedule and register for our other sessions. Thank you, Dr. Jones. We really appreciate your time and your dedication, and you've given some very practical advice. We had a lot of questions for families about how to organize their binders, what tabs we recommend, what reports we feel are important, and we'll get that information out in handouts as well. But if you take a look for, go to rettsyndrome.org under For Families, and I believe it's in the School and Communications section that you'll find some examples of an All About Me book. And we'll move that over into the Resources and Download section as well, with some additional medical tabs that we recommend that you add to that general All About Me book. Okay, thank you very much.
Paige?
Yes.
Could I add one thing? That I just want to say that that the reason we're doing this is because there is hope, and we want to keep our girls in the best possible health, and not to be concerned or alarmed, but to contribute as a parent to this best possible health, because there definitely is hope for the future, and we're excited about that. Thank you.
Thank you. That is an excellent note to close on. Thank you very much. We do think that the hope is very bright for our kids, and to keep them in the best health possible for that research is important, but also just to create a great quality of life today is incredibly important. And any advice we can give parents to do that, I know we appreciate from you. Thank you so much. Have a great day, everyone, and thank you for tuning into our webinar. Please answer our short survey that we send you so that we can fine-tune webinars of this kind as we continue on in offering family empowerment from rettsyndrome.org while we fund research. And I don't want to close without a thank you to Toby Dynavox and AmeriPride, our sponsors for today's webinar, so that you were able to attend at no charge. Okay, thank you very much. Have a nice day, and now we conclude our webinar for today.